Welcome everyone, it's Angelene True here. I'd just like to confirm that everyone can hear me and everyone can see the slide deck.
I can hear and see the slide deck, Angelene. It's Janine.
Beautiful, thanks Janine. I'm hoping that no one's having technical issues this morning. Right, we've got 12 participants. Janine, have you any idea how many we were expecting?
I haven't had a look today, actually.
Oh, sorry.
Natasha might be more informed than me.
Right.
That sounds about right. We'll probably have a few late people coming in late.
Rightio then. I think we'll make a start and welcome everyone. Online, we've also got Dr. Paresh, Dawda, who you've met obviously through the previous sessions. Before we make a start, have we got anyone online who's brand new, who's joining this stream at part C? No? Good, right. I'll work on the assumption that you all attended the previous sessions or at least have had obvious opportunity to actually look through the workbook and confirm where we're at in this. So first of all, I'd like to acknowledge Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands and pay our respects to their culture, their people and elders, past, present and future. So just to confirm, you've got myself, Angelene True, Principal Consultant at Prestantia Health, here on behalf of AGPAL, and then also Dr. Paresh Dawda, who you may have heard is online as well. So you've got the two of us in full or part as we go through. So in terms of the High Performing Primary Healthcare series, we'll just do a quick overview again. So it's supported and funded by Northern Queensland PHN through the Australian Government's PHN programme. And an overview of the series is provided here. So stream 1 we delivered, which was on the topic of continuous quality improvement and the QI PIP. Gary Smith delivered stream 2, which is about RSAGP standards and accreditation. And this is where we're sitting now. We're actually in the last webinar in relation to population health and digital health literacy. And we'll be coming back to present on integrated care along with Dr. Andrew Knight in the future as part of the programme. So in terms of the objectives of the overarching programme, so the High Performing Primary Care series, it's about building and strengthening workforce capacity within the primary healthcare setting. It's about working towards the quadruple aim in healthcare and fundamentally looking at the role and contribution of general practice in doing that. It's about embedding that culture for continuous quality improvement within general practice, and that culture of quality improvement and also the process of quality improvement being a foundational component of everything else we do within general practice. So then it's about leveraging of existing primary healthcare initiatives, and there's a plethora of those available within your community, both provided by the PHN and others. And then it's thinking through how do we actually extend and enhance the digital health literacy and that data engagement within general practice, because continuous quality improvement is driven by data, so therefore we need that digital literacy and the ability to drive data-driven improvement within our practices to actually achieve improvement. So then it's about thinking about sustainable primary healthcare. So how does this all work together? Just to stay in general practice and to drive value within the broader healthcare system. And on the back of that, it's thinking about how do we actually promote integrated care within our region to better support the patients that we serve within our general practice. So that's a quick overview of the series. In terms of population health and digital literacy, this is obviously a participatory workshop. We'd ideally like your involvement, so feel free to provide verbal input by taking yourself off mute at any point. Any questions, any queries, any comments, please feel free to interject. We want to make this as collaborative as possible, and then also provide your input via chat. Now, we will be using the whiteboard to actually record your feedback, but we're not expecting you to participate, actively participate in the whiteboard, other than give us the inputs, and Natasha will kindly document your feedback on the whiteboard. And just to advise, we won't be using polls today, but you do have your workbook that's got additional reading and additional resources in there. And there's a couple of activities that we'll allude to today that are actually in the workbook that you can take offline and consider back in the general practice setting. So in your workbook, you will be aware that we've got the knowledge capture sheet. So the knowledge capture sheet enhances your reflections and your learnings around, or captures rather, your reflections on your learnings. So asking the questions, what have you learned? What are the key issues? The so what being, well, what does this mean to me? What does this mean to my team? What does this mean to my general practice? And then the now what is an opportunity for you to document what you would like to do with that knowledge in response to what's needed in your general practice. This is a quick overview in terms of Stream 3 activity. We held the introduction on the 25th of February. We held the second session on the 4th of March, which was about intelligent information management, where we actually looked at and explored how you use data and information within the general practice setting. What tools and resources you have available to do that, what data you collect, or what data could you collect, and so forth. And then here we are in relation to designing the care delivery system. So thinking about how we use the data to identify patient needs, and then what interventions, what models of care can we put in place to address our population needs. For the learning outcomes for this session, rather for the webinar series, are reflected here. So the first 2 dot points were covered off in that first session, covering population management and the 4 habits of high-value healthcare organisations. The second session that we held thinks through about understanding your population and how do you use data to do that, about predefined populations and determining what meaningful questions you can ask of the data to identify gaps in care, population needs, so that you can use that to deliver proactive planned care. And then thinking through how do you actually utilise all of that to develop an action plan. So what do you need to do to redesign your care delivery for a given population of patients? That's where we're coming at. We're at the tail end of those objectives. But at this point, I'd like to throw out to you the 3 questions that we left you with at the last session. So those questions are: what data do you need to collect that you don't collect or engage with now? How could you better organise preventative and chronic care within your practice to meet the needs of your population and to reduce those care gaps? What systems and processes do you have in place to notify team members when routine or preventative care is due? So Natasha's going to capture your feedback on the comments. Paresh, have you got anything to add before we take feedback on this?
No, look, that's great. Thanks, Ange, and hi everyone. I haven't got anything to add. Be really useful to just see what your reflections are, and really just to try and reconnect today's webinar and workshop back with what we talked about last week, really.
Great, thank you. Righty over then, so over to you. Feel free to actually take yourself off mute if you want to feedback on any one of those questions, Alternatively, provide your feedback in the chat box. So Janine's come back and said we need to be setting up patient registers. And then participate in regular PDSA cycles.
Actually, may be worth just flicking across to the whiteboard.
Yeah.
So I think just really building on Janine, your comment around participating in regular PDSA cycles, I think one of the things we talked about last time was, the whole point of that intelligent use of data is really to be asking some meaningful questions, but then that's what allows us to think about for those different populations, and we talked about segmentation of the population. So even within like a population, you might have a subpopulation. So you might have all your diabetics, but you might divide your diabetics up into people with complex comorbidity, or people with extremely high HbA1cs. As a practice, you would look at and explore what are the meaningful subpopulations, and then how do you not treat all your diabetics in the same way in terms of how you deliver care, but do you need to redesign your care for those subpopulations? And I guess that's where the PDSAs fit in, isn't it? Because as you're going from perhaps current way of doing things to a new way of doing things, working out the right system, and then sort of what will work in your practice and what won't, will be around using the model for improvement and PDSA cycles. So I think that's a really critical paradigm we need to be having around that.
So Suzanne's added a comment here, Paresh, about apart from prompts now in top bar, still using the recall system within medical director, and the fact that that's screened by clinical staff, and in their instance, the nurses. Any comments or observations on that, Paresh?
I'm sorry, I'm just waiting for Natasha to finish typing that one. I think that's just come up on the screen. So yeah, so I'm not quite sure. Sorry, bear with me. I'm just going to flick back to open up the chat box and see exactly what it says in there. So using recalls and reminders with some health literacy info to get patients coming in. And then apart from prompts now in top bar, we used and still use a recall system within medical director, which is screened by clinical staff. In this instance is nurses. Look, I think that's a really great point. And what we're going to come on to, if I can maybe park that one, Suzanne, is what we're going to come on to. And actually, we're going to ask you a similar question a bit later. So we're going to talk about something called a scrubbing workflow. And we're then going to talk about top bar as well. And then really want to have a conversation at that point around the strengths and weaknesses of each approach, because my kind of feeling is we need both. Top bar is great and it's a really great tool, but maybe on its own it may not be sufficient. So we need to just make sure how our structures and processes are also aligned to allow that to happen.
And then there's another comment being added to the whiteboard, Paresh, which is around certain clear goals for the clinic. establishing registers and reviewing modalities that do not yield the desired effect. So utilising data to determine whether or not we're achieving the health outcomes we planned for or anticipated.
Yeah, absolutely. And I think that goal setting is a really important part of this, because otherwise it's hard to sort of make and track improvements. I guess what's really important around the goal setting is how you align the goals you set to. So there's this concept about big dots and little dots, which some of you may have heard about. So, you know, a big dot might be around reducing the mortality and amputations in our people with diabetes and our patients with diabetes, you know, but that's quite a hard one, right, to measure and monitor. So we talked about this concept about outcome and process indicators. And so maybe that our goals are more around the process indicators, because they're easier to measure, and you know we can track them and monitor them better. But we just need to make sure that we're connecting whatever goals we have around those process indicators to the big dot. You know, that sort of a big aim, big goal we're trying to achieve by setting up patient registers, by doing data cleansing, by having a proactive recall system.
Great. Thank you for that. I think that's one of those reflective activities you can do back at the practice. And I think it's also useful to have that dialogue with your team when you're thinking about building that digital health literacy within your general practice to drive quality improvement. I think it's often useful to stop and reflect and think about, well, actually, what are we currently doing and what could we be doing to actually drive that practice population management approach to better address our population needs. Now, I've swapped back to the slides. Can I just confirm that you can see the main slide? Yes?
Yep, Ange.
Great, thank you. So in terms of our objectives, what we want to do is identify the interventions to deliver optimal care. What we're going to do is describe in-reach and outreach within this session. And then, as Paresh mentioned before, in response to Suzanne's comment, we're going to talk through the use of top bar and the use of a tool called GoShare, which aims to build health literacy amongst patients. So that's what we're looking to do today. So at this point, can I just clarify, has anyone got any questions before we move on? I'm just going to do a little bit of reflection in terms of where we got, but in terms of our objectives for today, are you all happy with that? Any queries, any comments? No? Rightio then. So just a quick reminder then, we talked about Bodenheimer's 10 building blocks for higher performing primary health care with the ambition and the aspiration to work towards that top right-hand box there, which is about the template of the future. So that is fundamentally about high-performing primary health care and the key components that we need to address to actually work towards that. Obviously, within that, one of the foundational components is data-driven improvement. And as I mentioned, data then informs our quality improvement approach and underpins everything we do. So thinking about patient enrollment, patient registration, thinking about how we optimize team-based care, how we build on partnerships, what partnerships do we need to develop? So the patient team partnerships, thinking about the extended team as well as the internal practice team. But fundamentally where we're coming from today is around that population management approach, how we actually extend to continuity of care, how do we ensure that the data informs how we drive that continuous care, how we better address patient needs and gaps in care, and then also how we actually deliver comprehensive care that's coordinated to address individual care needs. So what we've talked about in this series is how we actually shift the organisation and use data to shift the organisation from that reactive response to patients and dealing with patients when they're sick, how we transition to a proactive response to patients, how we adopt that preventative approach to actually support them stay well, keep out of hospital, and actually engage with their own health care, self-management, health, to drive a better patient experience and health outcomes. So that's the paradigm we're currently working in, and it is challenging. Moving from a reactive practice to a proactive practice is very challenging because we need to have all of those building blocks in place to help us achieve that. We talked about the population health pyramid. So we talked about the stratification of patients and the need to address the needs of all of our populations. So adopting a panel management approach, and then looking to address the higher level needs of complex care patients and those that sit, those rise and risk patients, where health coaching would benefit them and try and mitigate the risk of them ending up in that top tier requiring complex care. So at that highest level, we're looking at the use of skilled nurses and highly trained health professionals to both address the needs of those complex care patients, but also undertake care management to ensure that patients get the care they need when they need it and actually sustain that continuity of care. So a health coaching can be delivered by nurses, your MPs, by volunteers and peers, by trainees within your general practice, and also by patient peers. And there may well be health coaching programs within your region. But the panel management approach focuses on the role of a dedicated team member, either the MPA, the nurse, or a trained receptionist, who actually utilises the data, scrubs the data as Paresh mentioned earlier, to identify what patients' needs are, what the gaps in cares are, so we can better address them on a proactive and planned basis, as opposed to that reactive basis we talked about. Now, at this point, I'm going to hand over to Paresh to talk you through the chronic care model.
Thanks, Ange. And I'm just going to remind people of the chronic care model, because we actually talked about this a fair bit last week. But I want to just remind you about this, because what I'd like to then do is move on to thinking about what we already do in our practices around chronic care model. What could we do? So current state, possible future state, and then really think about what those different activities are, whether they're in-reach, outreach, that sort of stuff, just to allow us to really deepen some of our thinking around how we can redesign that clinical service delivery to better meet the needs of the population. So we'll just move across. And so again, what I really would like people to do is, it'd be great. I mean, if you can't speak, then that's fine. But if you can speak, we'd really welcome a conversation around this, because with the putting stuff in the chat is great, but we don't get that narrative, and a lot of this is about what you're already doing in your practice. And so what we might perhaps start with is clinical information systems. So, we had some comments come up in that whiteboard earlier about patient registries, for example. So, that's probably some things you're already doing. And what would be useful to know is, Natasha, maybe we can just put a post-it called clinical registry or patient registries up. What would be really useful to know is, are there any registers you haven't got at the moment that you would like?
So, Dr. Paresh, can you hear me?
Yep, Amma.
Just the slide, the original slide was clear. For some reason, this new model, I just have a bit difficulty with the blurred and a bit distance. Can you go back to original slide when it shows clearly the whole slide?
Sure. Can
Have you got your workbook to hand?
I did I've sent you a message about the workbook you mentioned. You'll email it to me. I didn't get it from the
Right.
NQBH, whatever.
Okay.
Right.
Amma, can I ask, are you able to see the list on the right-hand side clearly or not? Is that...
Yeah, I could. So just, yeah, I'll take that back. I
Right.
can see it.
Can I suggest we have a look at the... Yeah, because the list on the right-hand side is really a bit more detailed information around the model. So we're looking at the sort of fourth bold heading on that list, clinical information systems. And so there's things around clinical information systems like patient registry systems. So I'm guessing most of you have some patient registers. It'd be really good to understand what ones you have, what ones you would like that you don't have at the moment.
Yep, get that.
Yeah. So maybe we could just have a conversation. If people could maybe just unmute and say what registers they have at the moment. So like, in our practice, we've got a diabetes register. We've got a register of people with coronary artery disease. We've got a register of people with COPD. We've got a register of people with palliative care needs because we do a lot of palliative care. We've got a register of people on opioids, long-term opioids. They're probably the 5 key registers we use mostly. What do other people use? What other registers do people have?
Hi, it's Emma at Sydney Street Medical, Mackay. How are you going?
Hi, good, thanks, Emma.
That's good. We're actually participating in 2 CQIs through the PHN. One is the the heart health. So cardiovascular disease is one of our focuses at the moment. So we're having a register for those and doing a lot of CAT searches and BP searches and actually bringing the patients in that sense. Mm-hmm. For the cancer screening program, we've actually incorporated that into our GPMPs and health assessments to a point where we're actually recalling patients in to either verbally refer them to breast screen or National Bowel Cancer Screening Program, and trying to link it up and doing a lot of background. It's all very hands-on in regards to data quality, but we're trying to get that done as well. So yeah, it's a lot of work, but on our end, but it's something else that's going to give patient care. And so they're the 2 big ones that we're focusing on at the moment.
Fabulous, thanks, Emma. What about others?
Are there any patient registers that you've developed in general practice that haven't necessarily been triggered by a PHN program? And I'm thinking about registers quite loosely in that regard.
So maybe to help thinking, one of the things we're thinking about in our practice, this is kind of on the wish list, is a frailty register. Again, because we've got a large cohort of older people, what would be really good is to identify degree of frailty and then have a frailty register. It's sort of one of our wish lists, and not quite sure how we're going to do that at the moment, but we're kind of thinking about that. So just wondering whether others are thinking about anything along those lines, or, you know, and depending on your patient cohort, whether you're thinking about another form, you know, another type of register. Alma, I seem to remember last week you talked about you have quite a few patients on Schedule 8 drugs.
Yeah, it was more about some, not schedule. Yeah, they come and they demand that, or other patients.
Okay.
I call them in general. I categorize them as a challenging consult. After I spoken to you guys and listen, I started my own just hand note. I'm new to this clinic, so I haven't talked to the practice manager to introduce register, but they're very cluey. They know how to do things, and I'm about to talk to them about starting this register about the concept. It will also help to see how to solve the problem and to educate other doctors and other members and students about how to handle that.
Great.
So I got paper hand one, but not electronic yet. I'm still very digitally very illiterate.
Yeah, no, I mean, and you know, this is all about continuous quality improvement. So, you know, you start somewhere and then you improve on that. And I often say, if you can't do it on paper, you're never going to be able to do it on you know, digitally. So there's no, you know, it's absolutely fine to start on paper, and then it's about how you make it more effective and efficient through using digital. So, okay, great. Well, look, we might just move on. So, you know, other things around clinical information system, in addition to sort of registries, is information on care management and then feedback of performance data. So interestingly, we just before starting the webinar, one of the calls I had was with our software vendor, because what we want to do is set up a clinical dashboard of a whole bunch of indicators around the different registers we have. And so the conversation I was having with our software vendor was, what can they do to support automating some of those dashboards? Just wondering what people are doing in terms of, you know, feeding back on that sort of performance data. So, you know, if we look at the cancer screening, for example, Emma, you talked about what reports are you pulling off and feed, you know, how you're building that feedback in to see whether the bowel cancer screening or the breast cancer screening in the eligible population is increasing. Have you done any work around that, Emma? Are you using any feedback loops using the data?
We have been doing, so we've actually been in contact with the both breast screen and bowel cancer screening programs, as in the actual organisation, to get searches done, so we can actually import it into our you know, best practice. That's the software we're using. So we can actually manually put it in, because it doesn't integrate with the software, because it's not HL7 in HL7 format. So we're doing a lot of background stuff with that. So therefore, when we do the CAT searches, it actually will bring up the patients that have had or are due or overdue for those screenings. In regards to top bar, I actually haven't really looked into that a little bit, and I'm pretty sure that you can probably do something in that sense. But it's mainly being best practice and CAT4 that we've been doing the searches on.
Okay, and look, let's park that top bar question, because we are coming back to top bar a bit later on. But that brings us really nicely onto decision support. And so, you know, top bar's one kind of solution for this. In terms of, you know, at that point of care, identifying potential care gaps and filling those in. Do people use any other decision support software? I guess health pathways. Do you have health pathways in your area, or map of medicine?
Most definitely have health pathways, and
Yeah.
we use that a lot.
Okay. Great. So, you know, that's an example of decision support, I guess. What else do people use? Any other decision support tools? So, you know, I think in where we are in Australia at the moment, I think those sorts of tools are probably the most common. Then, you know, people are using. They're probably not decision support tools, but they're more electronic resources, such as, you know, Up to Date. I know some colleagues subscribe to, and, you know, medication formularies, whether it's MIMS or Australian Medicines Handbook. So people are using sort of electronic tools, you know, digital tools at that point of care, but not always, you know, I wouldn't, is it decision support, or is it just more an electronic reference? I think it's probably more an electronic reference rather than decision support tool. One of the other tools I use a fair bit of is like an electronic opioid conversion tool for morphine equivalent doses. That sort of helps with decision support, and then if you're changing and doing an opioid rotation, helps you work out the alternative doses and things. But I think this is a space where we'll see things rapidly evolve as well. So I've been involved in some projects around clinical analytics. So how do you use AI, for example, to pull the data that's in the clinical record and then provide a degree of options around decision support based on the records you have. The idea being to try and free up our cognitive capacity as clinicians when we're consulting, by not having to, you know, think about these things, but just having it presented to us, then to have that clinical conversation with patients.
Paresh, can I just clarify? Do you think the patient activation measure is a decision support tool?
I wouldn't describe the patient activation measure as a decision support tool, to be honest. I'd probably describe it more as a patient-reported measure. I probably would describe it more as a patient-reported outcome measure rather than an experience measure.
And where would that then fit on the chronic care model?
Yes, I would put that in, you know, if we look at self-management support,
Yeah.
I would put it in that box, because, you know, it's an assessment of where people are in their knowledge, confidence, and skills to support their own care. So that's where I would put
Right.
the time score.
Radio.
Other thoughts, other comments? So does anyone use partners in healthcare, which is, you know, one of the tools that was advocated by the CVC program? So, you know, that's another example of something that could go in self-management support. I think GoShare, you mentioned earlier, Ange, you know,
Yeah.
that could fit into self-management support as well, because that is about patient education and health literacy development.
Paresh, one thing I've just found by this conversation is that I probably aren't all over this as much as I should be, because I do know that the GPs and the nurses have different platforms that they utilise for their care of their patients. But me as a practice manager and owner, I'm sort of like, because I don't actually use those softwares, I'm sort of out of touch with it. So it's probably brought up a good thing that I probably need to bring it all in again and see what everyone's using and make sure everyone knows they're using different tools, and just in case other doctors don't realise that tool's available.
Yeah, and look, and you know, the idea of doing something like what we're doing at the moment. So what we're essentially doing is a mapping exercise, right? So we're saying, look, there's this brilliant evidence-based model around managing chronic disease called, you know, and that's what this diagram is. What are we doing that we can map onto this model? Because that way we can identify, you know, our strengths, you know, things we're already doing, because I'm a big believer that we take a strengths-based approach and work on our strengths. But at the same time, we can identify some potential gaps as well. And then we can sort of start that developmental journey around how we fill the gaps. Because in an ideal world, we want to be doing something across all of these different dimensions. And so that's exactly the kind of purpose. So thank you for highlighting that, because as we start, you know, it just helps stimulate our thinking. And as we start thinking about it, we can, you know, we get ideas around this, don't we? So I might just think about delivery system design. What do people do currently around delivery system design? So if you look at the text on the right-hand side, that gives you some ideas, right? So proactive follow-up, care delivery, coordination, team-based approach, care management roles or case management roles. What do people do at the moment? Do you all have a proactive follow-up system for your people with chronic disease?
We actively do the recall system through obviously our clinical software, but I also like to double check to make sure people aren't being forgotten, because people do slip through the gaps. So we do have a normal recall system where SMSs go out to patients. They have 3 SMSs, and then a letter is either sent, or when the letters are printed, or the search for the letters is done, the nurses will actively physically go through them and contact the patients via telephone. If that's unsuccessful, they actually send the letter as well. So, and then we're doing another search behind the scenes of those that have got reminders that have not been actioned, which we find that the doctors have a difficulty in utilising the software appropriately to marking off that they actually have actively done the work that they've, you know, spent the time doing. They just haven't ticked a box or something. So that's what we're actually physically doing at the moment.
Okay, so that's a great example of proactive follow-up, and actually within that we've got a great example. Within that, we've got a great example of using clinical information systems as well. You know, with how you're using the reminders, and then you're doing a second search to work out the reminders which have or been actioned or not been actioned. So that's great. I'm just mindful of time. So what we might perhaps do is just think about this. And now we've kind of had a bit of a conversation about what you're currently doing. Would really like to think about what you're not doing, but this conversation stimulated for you around you could be. So your kind of ideas for improvement. So, you know, we heard something earlier about, I think, was that you, Emma? I wasn't sure. Sorry, I didn't see who was speaking to that earlier, but, you know, around not knowing the tools clinicians are using. So one idea for improvement is, let's work out the tools people are using and see whether we can do some cross-fertilization around that. Just wondering, do people have any ideas for improvement that you could use in your practice?
I think one of the biggest improvements that we need at our surgery is clinical software, using it better to the best of its ability, and top bar. That's a constant struggle of mine, trying to get everyone to open up top bar to use it, because it's a fantastic tool for people that are actually in the practice. Another one we're actually trialing at the moment, we're putting one of our admin staff through their medical assistant training. So, and utilising them a little bit better, because we're finding that new patients aren't seeing the nurses because the doctors are, they're running behind time. And so we're trying to get everyone, so all patient information is up to date and entered into the software.
Mm-hmm. Great. Any other ideas from anyone at all?
I hate to talk again, so it's silence. One thing we're actually looking at, and this is only a thought at the moment, is more patient education outside of the consultation rooms, like be it in the waiting room, on our TV screens, actually developing something, or getting providers in to actually have chats to patients as groups about, because one of them has been falls prevention. So April is the month of falls prevention. So we're thinking about trying to get some more education for patients.
Absolutely, great. So that's, something that kind of fits with that self-management support, doesn't it, about building health literacy and things. So, you can start to see how you can use the chronic disease model, look at what you're currently doing and what where there's opportunities, what's perhaps missing, to try and design that, clinical microsystem, your kind of way of delivering care. And we're doing it fairly generally, right, at the moment. So we're just sort of picking our brains and saying, what are you doing in your practice? But you could, if you're working on a particular project, like say cancer screening, you could actually just narrow the scope right down and say, how are we using our clinical information systems with respect to cancer screening? What decision support are we using here? Brilliant. A few years back, I was involved in a study being done by Addenbrooke's Hospital in Cambridge in the UK, which was around using an electronic tool to fill out the family history around cancer. When you do that, it started then to sort of give a risk based on that family history around looking at genomics, and particularly for people with breast cancer, this was on around whether they've got background risk or they've got risk above background risk, and then tailor the intervention and the referral pathway based on the level of risk. So that was like cancer prevention, looking at clinical information systems, recognizing family history is a bit of an issue, then using a decision support system to help decide what the risks were, and so on. So what we'll do is we want to really to get you to have a bit of a feel around this, because this is something you can go back and do in your own practices. And then the next thing you can do, and what we're going to do, is just flick over to the slides just for a moment, and then we're going to flick back to the whiteboard, is to really think about the concept of in-reach and outreach. Has anyone come across this sort of concept before?
I've seen it, but I actually actively haven't done it here in the practice.
Okay.
Yeah.
So what I might do is maybe rather than just flicking, this is just one slide, I might just talk to the slide. So basically, there's a concept of in-reach and outreach. So in the context we're talking about with in-reach, the idea is when people come into the practice for whatever their appointment is, we try and maximize the care around everything. So, you know, somebody might be coming in for, let's just say, a sore throat. We recognize that someone's coming in today. We look to see what the gaps in care are. Well, that's where tools like, I guess, Top Bar and things can help. But we look to see what the gaps in care are, and then we put in place a mechanism to make sure that when they're here today for their sore throat, we actually try and do everything else as well, as much as possible, and fill those gaps in. Now that creates challenges because, you know, they might only have a short appointment booked, and to do everything might take you 3 times as long. And that's okay to highlight those challenges, because it's then about how do we design the system, how do we design the team, so we can still accommodate that sort of in-reach care. So that's what we're talking about with in-reach. What we're talking about with outreach is to say, you know, here's a bunch of people, we don't necessarily, you know, we might not have seen them for a while, but they've got gaps in their care. What can we do proactively through reviewing their records, through reviewing the data, to then reach out to them to provide that care? So they're just 2 fundamental concepts. And, you know, I have to say a lot of these concepts, well, both these concepts were probably developed when things like telehealth wasn't around. And there's a sort of a merging of the concepts, I think, with telehealth around what's in-reach and what's outreach. But that's, you know, that's perhaps a debate we won't have at the moment. So, you know, the third thing we can then do is to say, well, out of some of, you know, out of these activities, which activities are about in-reach and which activities are about outreach? So we can, you know, we've got different colored dots at the bottom here. And I'm going to pick one and just talk about huddles. So huddles is an in-reach activity. So what huddles is about is making sort of team-based care work. So when we're thinking about that in-reach stuff, what we're trying to do is say, you know, we've got this patient coming in today with, you know, or we've got this list of patients coming in today, including this patient with the sore throat, and the huddle would be between the GP and, you know, let's say the practice nurse or the medical practice assistant. The huddle would be to say, look, these are all the patients we've got coming in. Here are the gaps in their care. This is what we can realistically achieve today. Can the practice nurse help with that? Can the medical practice assistant help with some of that? Because they've only got a 15-minute appointment. So literally what we do every morning is we have patient advocates who sort of, probably the best way to describe them are like they're a medical practice assistant or a healthcare assistant. So they've got some clinical background or some clinical context, but they're not necessarily clinically qualified. So they would prepare a list the day before of everyone who's coming in, what the reason they're coming in for, if we know that reason, so we can make sure that we've got things prepped for when they're coming in, but also the care gaps. So, you know, this person's got smoking history, absent, they haven't had a blood pressure in the last 3 years, and actually they're about to turn 50 and they need bowel screening as well, or be reminded about that. And so, the way the conversation would go then is the GP and that patient advocate would then say, okay, great, well, look, can you maybe talk to them about, do the blood pressure, maybe give them an information sheet on bowel screening because they're about to turn 50 and they'll get a point or a kit through the post from the National Register. And then we'll move on to the next patient. So what we're trying to do is in reach and maximize the patient that's coming in on that day, the sort of care for that patient. Top bar is an example of that. Top bar is making that process a little bit more electronic, and we'll come back to that. We can also do outreach. So and a lot of us probably do outreach. So I think Emma, I think you identified looking at the data you're using and then reaching out to patients who perhaps have missed out on a cancer screening or an element of cardiac care. And so that's essentially outreach. And so again, when we're thinking about how we deliver care, it's useful to think about in-reach and outreach. And you'll see that we can get more detail with this depending on patients' own abilities to manage their health as well. So for some patients, we might do more in-reach type of activities because they might have a lower degree of health literacy and patient activation, whereas someone who's very knowledgeable and aware of their health, we might do more outreach type of activity, or might do a telehealth with them as opposed to a face-to-face. So we can really get sort of granular with that. Does that make sense to people?
Yeah, most definitely.
Yeah. So one of the things, if we think about some of these things and making them happen, we've got a very clear issue here around it's a whole team activity. It's not like one person can't do it. So how do we enable that whole practice to do it? So one of the ways is using a sort of standing order type of approach. So maybe, Ange, we could flick back to the slide. So here, and I guess what we're saying about standing orders is to say, we're giving the authorizing environment for people to work at the top of their license, essentially, right? So what we're saying is, as a doctor, I don't need to decide who has an HbA1c and who doesn't for my diabetic patients. There's pretty good evidence around this. We know HbA1c is a great proxy outcome indicator. Let's just create an authorizing environment. So if you, as a practice nurse or the patient advocate, identify the fact this person needs an HbA1c, don't wait for permission from me. Let's get on and organize that for the patient. And now we may have to work around the system a little bit, because at the end of the day, the doctor with their provider number needs to sign the pathology form. But if I've got confidence in the practice nurse or the patient advocate identifying these people, presenting to me a bunch of pathology forms to say, we've looked at your diabetic patients, these are the ones who do an HbA1c, can you sign this pathology form? And then we'll send them out and contact them. Then I will be happy to do that as a GP. So we have to have those little workarounds because of the way our system's designed. But the principle is, let's allow everyone to work to the top of their license. And in order to do that, we need to create an authorizing environment, but we need a governance around that authorizing environment as well. And so standing order is a way of setting up that governance, is to say, and here's an example, right? So every month we want the person looking after the panels. In our practice, it would be the patient advocate, to identify all the patients who've had an HbA1c above 7% and have not had a test in the last 3 months. If they're and then what we want you to do, if with those patients you identify, is do a pathology request for an HbA1c. We'll also sort of give them a bit of information and do a letter around that. And then we'll do a follow-up call in a couple of weeks' time for those who we haven't received the pathology back on. And if the patient happens to have an appointment by chance in the practice in the next week or two, we'll do the HbA1c at that time. And so the patient advocate's been authorized to get on and do that to make it happen.
And that's an indication, Paresh, in terms of how we're moving from that reactive care to the proactive care, and about creating the environment for team-based care where people are actually given permission to act for the benefit of the patients that we serve.
So if we move on, Ange, the next slide is really talking about something called the scrubbing workflow. So the idea of this is, again, you use the team to do this, right? Is you identify the key health conditions that your clinic will scrub. So it could be heart disease, it could be cancer prevention, it could be diabetes, it's where your priorities are as a practice. You identify a couple of team members. To look at those kind of gaps in care for people who've got an upcoming appointment. You document those gaps in care and who identify those gaps in care. And then you huddle before the session. So that was what I was describing earlier with our huddle process. We can use technology to do some of that. So we can use TopBar. And so the next slide is actually a video of TopBar. And before we actually go and play the video, what I might do is just hand over to Ange at this point as well. And then unfortunately, I've got to jump off the call because I've got to have I'm chairing a meeting with the Department of Health, and I'm got to be there for a particular agenda item. So my apologies for that. But then I'm going to come back as soon as that agenda item's over. But I'll leave you in Ange's more than capable hands. Thanks, Ange.
Yeah, thanks, Paresh. So what we're going to do now is show a very quick video on TopBar, just to make sure everyone's familiar with it. But TopBar is that clinical decision support tool that we talked about. So that automatically generates flags for the clinician. But in addition to that, obviously, we need to understand in terms of how we use our knowledge in addition to that, or how it informs our knowledge. Let's just see how we go. Can someone give me feedback that they can hear okay?
Welcome to our brief overview video on our decision support tool called TopBar.
Yeah.
TopBar is a point-of-care decision support tool that presents information about your patients. It highlights missing data items and facilitates complete patient care. There's a huge amount of clinical and other information in a patient's electronic record. However, time is limited and every minute spent with a patient is important. TopBar will analyze the patient data as you open the patient's record and will present recommended activities and highlight gaps in the patient's record. This video shows TopBar with Medical Director, but everything shown works exactly the same way for best practice users. TopBar is designed to work discreetly and to complement rather than to interrupt your workflow in the clinic. It is a tool that can be used by all staff who have interactions with patients, be they clinical or non-clinical, and will assist you in providing quality healthcare with your patients. The first app I want to show you is the waiting room app. You can see there are 4 people currently waiting in my clinic. The notifications are always shown in the little red circle, so there are 7 notifications for these 4 patients there. Clicking on a patient will show more details, in this case missing gender, contact number, Medicare number and ethnicity, and the other items below are completed. to enter them, you can click on the Add in Clinical System. In this case, it will open up the patient in Praxsoft and allow for simple entry or update of the information in there. So we're just entering the gender, and by the time it's saved in the clinical system, it's already updated in Topbar, and other things can be done. This is a very useful prompt for receptionists to keep patients' record up to date based on accreditation guidelines. These are the things that the college recommends patient record should contain. So if we're moving into the consult room now and opening up a patient in our clinical system, and that will activate a number of other apps in Topbar. You can see there are more notifications there. Starting with the data cleansing app. So for my current patient, I have 10 notifications, and there are 3 different tabs really. The demographic one, same information as in the waiting room app. Under clinical, we're showing information such as allergy status missing, risk factors, alcohol and smoking, again aligned with accreditation guidelines and simply to be added by using the Add in Clinical System button there in top bar. Now with entry in patient's record, free texting often is a problem. So we've got our indications tab there. Currently looking at diabetes, COPD, osteoporosis, mental health and chronic kidney disease, and we're trying to find patients that have indicators in place but have no coded diagnosis recorded. So that could be either a free text diagnosis or just nothing recorded at all. And in this case, we're looking at a long-term prescription of anti-diabetic medication. We're looking at pathology results for HbA1c and a fasting blood glucose result. These 3 together form a reasonably strong indication, in this case indicated by the red color of the status there, showing that this person is quite likely to have diabetes. And to update that in the clinical record, again the option there to click on Add in Clinical System will open up the patient's file and allow you to enter a properly coded diagnosis or a new one if there's nothing there at all. So that will keep your registers up to date. It will also activate the built-in warnings of your clinical system. They don't work for free text. And you can see now we get a green tick there for the type 2 diabetes. And last but not least, we have filters to customize Topbar on a per user base if you wanted to show only particular prompts or notifications. The next app, the MBS app, you can see there's certain medical items that are relevant for my patient, and because of the diabetes there's a GP management plan and a diabetes cycle of care. We're looking at diagnosis, age, gender, ethnicity, medications, and of course the billing history at your practice to see which items are relevant, which are due or overdue now, and which have been claimed lately. And there's a number of non-relevant items that can change, of course, with a new diagnosis. For example, for mental health, then the mental health related items would become relevant items. You can click on an item to see further information or enter, particular for the diabetes cycle of care, individual components of that cycle of care to mark them as complete. This will also ensure they go into the right field. And in the settings you can change the schedule. If you want to work with the Medicare schedule, the 12 months or 3 or 6 months, then you don't have to change anything in there. The Patient Health Summary app shows a summary of the patient record. Currently it's a static list just showing things like medications, encounters, family history and so on. Useful for locums or visiting doctors, but there is some activity planned on there that will come in future releases. Moving on to the next app with the CAT prompts. So if you're using CAT 4 already, our population health tool, you can create prompts and notifications in CAT based on a search, which can then notify the clinicians when a patient presents. So I've used a search for a high-risk respiratory patient, being a smoker, who did not have a spirometry done. CAT will find a list of all of those patients, and when you create a prompt, as soon as a patient presents that meets the criteria, this notification will become active. So if you're using CAT already, I encourage you to have a look at that. It might be very useful for your practice, just as a communication between the CAT 4 users and the clinicians in the consult room. Much more efficient than passing a piece of paper into the consult room with the patient. And these prompts are dynamic. So if this prompter is entered, the prompt won't happen again. The Healthcare Homes app. Now, this won't be relevant to everyone. I just wanted to show you that we have a very simple app there to flag patients as enrolled. You can select the tier. So if I say I want to flag Maureen as enrolled in Tier 1 Healthcare Homes, that's all that's required. And this will allow the analysis of the Healthcare Home trials to work to basically enable them to see has the Healthcare Homes been effective. You get a green tick there at the app, so other users at the clinic also can see who your patients are that you've enrolled in the Healthcare Home trial. Now, if you're interested in Top Bar, 90% of the PHNs have purchased licenses and they're available for free to you. So please contact.
I'm just going to pause the video there. I purposely left in the Healthcare Home demo. I could have stopped at that point. And the reason I left it in is obviously I'm party to the Healthcare Home Tribe, the National Lead Facilitator for Healthcare Homes, myself. But I left it there because one of the key components that Healthcare Homes has, reflecting back on Bodenheimer's building blocks, is patient registration. And the ability to register your patient, empanel your patient with GP clinical micro teams, and then look to stratify the patients and develop registers of patient needs is one of the key components of the Healthcare Home trial. So I just left it there so you can hopefully see the benefit of patient registration and how it enables you to actually stratify your patients. So there we were using the 3-tier, so the McKinsey's stratification, to classify patient and then use that to help us determine patient needs. So key takeaways from Top Bar. So my key takeaways from Top Bar, not being a clinician and not working physically in general practice, is around the fact that it's an extremely useful tool, but that tool is only as useful as the quality of the data that's in the tool. So I think someone mentioned when we were looking at the chronic care model, the fact that not only would they look to map what tools are currently used within general practice, but look to think about how we educate people within the practice to better utilise those tools. And then as part of that, there's a need to obviously think about, once you've educated people, how do you actually build up the quality of the data? Because without the quality data, you don't necessarily get the benefit of the system. You can't necessarily get the benefit of those algorithms that are built in the system that help identify where the gaps in care are for patients. You don't then get the benefit of the ability to codify patients according to their credentials and therefore build your register. So quality data underpins all of this. But interesting, Top Bar as well, not only gives you those prompts in terms of gaps in care, not only gives you those flags to help look at what potential diagnoses have been missed and those clinical indicators you need to further investigate, but it also gives you that idea in terms of what's MBS billable, what's not, what's potentially available based on the patient's conditions and their needs. So not only is it a useful clinical decision support tool, but it's also very much a management support tool as well. So it's got that capability in. But those care prompts that we talked about in terms of the applications there and the notifications you received. So when Paresh was talking about the use of huddles and the ability in his regard for his patient advocate to go through the patient records, scrub the data using Top Bar to identify unmet needs. So Top Bar is a very useful tool, clinical information system tool to help you, and decision support tool to help you do that. So has anyone got any feedback on the use of top bar, recognizing the fact that obviously there's the ability to engage with the digital health team within the practice to help support your capacity building? Any questions on top bar before we move on?
Yes, Angelene, it's Ahmed. Can you hear me?
Yes, hi Ahmed.
Now, how in our clinic we use best practice?
Yes.
How could we? I'm a bit confused. How can we get the top bar into best practice? I don't know.
So best top bar is compatible with best practice. I'm assuming your practice doesn't have top bar.
No, we don't.
Right. I think, well, you've identified an opportunity for improvement within your practice. Janine, would it be appropriate for you to follow up, or the digital health team to follow up?
Yeah, as Amar is not in our PHN, we don't fund, unfortunately, we don't fund top bar for him, but I would encourage him to reach out to his local primary health network because they may have a similar data program that incorporates top bar as a tool.
So let me get that right. So if the practice manager and the team here are agreed to put top bar with our best practice, with the data from best practice for those patients automatically get into the bar, or should the receptionist or someone, including myself, record the data both on best practice and top bar? Yeah, which way?
No, that's correct, Amar. What it does is it sits over the top of your practice clinical software, and so you don't have to duplicate any data entry. What you do is you set up some filters through top bar, and then it identifies those patients as they come into your practice and just flags the missing information for you. So it makes it a lot easier for you to know as a GP what's missing in your patient record, and therefore you can sort of look at MBS items claimed, you know, for PIPQI, you can identify missing demographic information. Even with your immunisations, you could set up, you know, something in relation to COVID vaccination and identifying other parts of the data that may be missing. I could send you some information if you like.
Yeah, that would be great. So I can flick it to the practice manager and discuss with her.
Sure.
Thank you.
No problems. I'll follow up with you.
Great, thank you.
I just wanted to say it works really well as well in practice. It's a very good tool, and it works with Cat4. So if you've got Cat4, once you get that tool as well, you can do all your searches and it actually extracts information so you can actually follow up with patients. So a very good tool to have.
Yeah, I don't have any cat, and I have only the best practice. That's why I'm asking. But thanks. I'll check it up. Thanks.
Fabulous, thank you. I'm mindful of time and there's a lot for us to get through, but I mean, obviously I identified a developmental need within the
Take your PHN or pencil.
So let's quickly move on. So ways of conducting outreach. So in terms of outreach, where we talk about being proactive and pushing out information to consumers to either build their health literacy or pushing out communications to actually engage them back with the practice, their cycle of care, to better address their care gaps and so forth. We've got different mechanisms to do that. And as the health system becomes more digital in terms of, and automated in terms of what the capabilities are, we've got things like the use of robocalls, things like the use of e-messaging. And just to clarify what they are, so robocalls are basically where your system, your IT system identifies a patient need, and your IT system, through the use of AIS, determines that it can reach out based on algorithms built into the system to determine what's appropriate, reach out and send communications and calls to a patient to prompt them to either undertake an activity to support their health plan or alternatively to connect with the practice. So the illustration Paresh used, for example, was around pathology for diabetic patients. And similarly, the e-messages, so they are automatically generated by a system. So other outreach capabilities that you'll have access to now is obviously the use of letters, the use of MS, SMS, and then also the ability to actually get on the phone and reach out to patients to communicate with them. So we talk about synchronous and asynchronous communication. So phone calls or an illustration of synchronous communications. It's real time, it's engagement between you and the patient at that point in time, but the rest of it is asynchronous communications. So they can be done, they can be batched and done together, pushed out to patients. So your robocalls, if you have a system, could be generated overnight and then pushed out to consumers. So I worked with the Australian Institute of Sport to develop their communications portal with all their key stakeholders, and they have integrated that capability within their systems. So this activity here, we very quickly want to run through, mindful of time, ask you to consider what activities can be delivered virtually and what activities absolutely need to be delivered face-to-face within general practice. So if you think about your patient cohort, the population you serve, so think about the different levels of needs for those patients. What could we do, or what do we need to do absolutely face-to-face, or what can we do virtually now with the benefit of things like telehealth to address patient needs. So I'm just going to switch screens, and then in doing that, switch. Slides. So again, Natasha's very quickly going to document these. Do you want to do a few quick shout outs? So what do we do face-to-face? That has to stay face-to-face. What can we do virtually? What absolutely needs to be done virtually?
Well, some of the virtual things can be like if you've got data quality for a CQI, or if something like if you've got the HbA1cs that are due, some other, the patient information needs to be updated, and patients can actually get a lot of their health assessments done virtually, but a portion of it will have to be done face-to-face, such as like blood pressure and heights, weights, and checking mobility and that sort of thing.
So can I just clarify, who was that? Sorry, I haven't got the participant list.
Sorry, it's Emma from Sydney Street Medical.
Emma. So sorry, I'm just going to challenge you, Emma, because you said some of this, sort of the screening and the diagnostics need to be done face-to-face. So if we think about the development of digital health within the Australian healthcare system, there are tools to actually help us do what we would typically have done face-to-face within the general practice via virtual care. So for example, taking of blood pressure and things like that, if you think about the use of apps. But there's also tools that can be located within patient contact points. And I'm sorry, the name of the product doesn't spring to mind, but those tools actually exist. So whilst we're thinking about what we need to do now in practice, in the future, there's a lot of that could be done virtually by the use of digital health technology. But you're right, at this point in time, yeah.
And I think that some of the patients who have the facilities at home, like they might have a blood pressure monitor, they may have things that actually they're able to show that they're actually physically doing it and they can virtually see, that's perfect. But those that don't, that have to go in. Oh, and Janine's just said Bluetooth devices as well, which is fantastic.
Great.
So
anything
mental
else
health assessments would be able to do virtually as well.
Sorry, I missed that, Emma. What was that?
sorry, I keep playing. Mental health assessments.
Yeah.
It can be done virtually. Now, this is if telehealth continues beyond the 31st of March.
Yes. So it's contingent on a decision in terms of whether or not you're authorised to deliver care by telehealth. Yeah. So Emma's put a comment here. So as a GP, I need to see the patient briefly before asking them to do other things. So including forms and diagnoses, so DAS 21 and so forth. Yep.
Yeah, I'm sorry, not forms like family history, including cancer background and other family conditions. So
Yeah.
I can decide what's need to be screened for them for a health check. OSA is for the obstructive sleep apnea, which is a special question, which is time consuming. So I give it to them to do it outside. And the DAS 21 for mental health check. Just for example, to fill this one takes more than half an hour. So I see the patient briefly and cover other things, which is in reach, as the Paresh was talking before. But for something which is very, I would call it virtual this way, because they're filling them out of there. But
Yes.
I don't initiate anything virtually without seeing them, except responding to a test, for example, saying that, come and see us.
Yeah. Yeah. So there's a need to have a relationship with the patient. There's a need to eyeball your patient at some point within their cycle of care. But this is illustrating that actually a lot of what we can do can be done virtually if we've got the permissions and the authority to do that. The technology is there. So some of the diagnostic tools, online diagnostic tools that could feed into the software system as part of the decision support tools within the system and so forth, but also the technologies to undertake screening of patients when they're in different settings. I'm mindful of time, so I'm just going to swap slides again and then push on. But this again is another useful exercise, probably timely to do when we get an idea in terms of where the Department of Health is going to land in relation to the use of telehealth. But it's something that you can do in-house. Sorry, I'm just trying to get the right slide. So something you can do in-house to actually start that conversation in terms of how can we actually change our model of care to both better address our patient needs, but also make our practice more efficient and effective. So picking up on that sustainability agenda. But one of the caveats we have in terms of whether or not we use in-house or out or virtual care is around the need of the patient and the ability of the patient to actually engage with virtual care. So what we need to do is actually stratify our patients to work out what level of support, what type of support, and what model of care would be best appropriate for our patient cohort. So this looks at patient activation and patient complexity. So if we had to think through sort of that in-reach, out-reach, so in-reach is obviously about patients coming into the practice and looking to address their needs while they're in practice. So that would involve a lot of face-to-face activity. So in terms of that type of patient, where do you would think they would sit in terms of their activation? And where would you think they'd sit in relation to their complexity or their disease burden? So my perception is the fact that they probably sit in that bottom left box. So they need higher touch points. They need more interaction, more face-to-face interaction, low levels of activation. would help us determine what level of care we'd be providing, what type of care we'd be providing to them. And what we're looking to do with those patients is actually take small steps with them to actually build up their capability, their knowledge, working towards their identified care goals. But on the top right hand side there, we've got the very highly activated patients. They might have a high burden of disease. They may have previously been high utilisers of general practice and healthcare services, but now they've got an understanding of their condition. We can classify them as an expert patient. So they're health literate. They've got a high level of self-management capability, a high level of activation, so they're proactive in their care. So arguably we'd need lower touch points with those patients. And potentially we've got the opportunity to use those asynchronous communications where we simply pushing messages and pushing communications out to them that we know and we're confident that they respond to. And those patients will probably more likely engage and be more satisfied with that telehealth arrangement, so the virtual care. So we can see the need here to actually segment our patients. And we do that by understanding the patient needs, their complexity and their level of activation in doing that. So thinking about how we then apply that, how do we actually segment our patients to better address their needs? And we touched on this in the last session. So thinking about that population management approach. So that's a proactive way of making sure all of our patients receive all the recommended chronic and preventative care components. So it's not necessarily dependent on whether the patient comes in for the purpose of preventative care, or even if they come in at all, but it's about establishing a panel of patients and making sure that panel of patients actually receive the care and the interventions they need. So you may do some call recall with them, depending on what their conditions are. So in terms of the next level of needs, so if you think about the Kaiser Permanente stratification level, and those people we had at tier 2, think through what their needs are. So these I would class as rising risk type patients, where they have chronic conditions, potentially multimorbidity. And what we need to do to ensure that they have that self-management or enablement capability is actually coach them on their conditions so they understand what their condition is. For example, with diabetes, we understand what the clinical indicators are that they need to be mindful of. And then we need them to understand, for example, what to do on a sick day. So what to do on a well day, so that they build up their capability and their health literacy to better self-management, so they don't end up with a higher burden of disease. They don't end up with poorer health outcomes. And what we do is we address that risk of them being high utilisers of both general practice and the broader health system. So very much aligned to the quadruple aims. So how do we keep these people well and out of hospital? And one tool to help us do that is health coaching. And this is where members of the practice team actually work collaboratively with patients to give them the knowledge, the tools, the skills and the support to better manage their condition. So we can use that in the practice setting, but it's also used in chronic disease management clinics in the specialist setting. So for example, here in ACT Health, we have a number of specialist nurses within our health hospital and health service system that work with those rising risk patients and also tier 1 patients to educate them in terms of how to better manage their conditions and live with that condition. So it's about improving the health behaviours, improving self-management capability, and also that of the carers. It's delivered by trained care team members, so staff who are actually trained in health coaching techniques. And it can either be delivered to individual or groups, and extending that, it can either be delivered face-to-face in practice or virtually on a virtual group setting. So if you think about leveraging the use of shared medical appointments, for example, the shared medical appointment not only addresses the individual need at that point in time, but it also provides the ability to get a group of people together to do some health coaching. And then the add-on benefit of that is it helps establish peer support networks and peer links to sustain the individual outside of that general practice interface and setting. So 6 key components of health coaching include ask, tell, ask. And I'm assuming you all understand sort of these techniques because they're fairly common within general practice. So ask, tell, ask is a method we can use, closing the loop to ensure that we provide feedback and the patient provides feedback. Agenda setting, so if you think about care planning, shared care planning, sitting down and actually establishing goals of care, which then aligns with the action plans in terms of how we work together to actually address those goals of care. As I mentioned before, in understanding what clinical indicators and numbers mean, why they're important, how do we and the patient monitor them, and what to do if a red flag's raised. And then also that 6th component is the importance about medication adherence and counselling around medication management and adherence. So building up patient health literacy and self-management capability by ensuring that they understand how important it is to manage their medications appropriately. So thinking about older patients, thinking about people on multiple medications, that's obviously very important. So in terms of health coaching, we work collaboratively with patients. We do it together. As I mentioned, either face-to-face, virtually, individually, or group. If you think about a low activated patients, where we highlighted earlier, we're going to need to take little steps. You could potentially come to the conclusion it's better done one-on-one. And what we will do is we'll take incremental steps to build up people's health literacy and also their self-management capability. So I work on the basis that every patient contact is a health coaching contact. So we need to build that into the system. It needs to be undertaken on a gap analysis. So let's work from a strengths-based approach. Let's determine what the patient knows now. Let's look at what the skills and supports they have now, and then let's work from them. It's about providing tailored information and tools, recognizing the level of activation, recognizing the level of knowledge and skills of the patients, and then thinking through how do we actually support the patient to build their confidence over time to better manage their condition. So it's about enablement, it's about empowerment, and the way we do that is through that engagement and participation. Not only is it proven to actually improve the patient experience of care, but actually the provider experience of care. And back in the UK, I actually evaluated 3 programs, 3 of the expert patient programs, and that was very much one of the conclusions drawn from those evaluations. So what I want to do with you, let me just check the time. We've only got 15 minutes left, so I'm proposing that I actually skip this. But what I'd like you to do is actually utilize the link that's available on the slide in your handbooks, and actually just run through this very short video on Go Share. So this is a new tool that's been developed and is being integrated within general practice in New South Wales. And what it does is it creates a catalogue of all health literacy and self-management tools that are being developed. So there's an assurance process that sits behind it. And what you can do is you can integrate it into your clinical information system. So once you've had an engagement with a patient and you've determined that they would benefit from additional information or additional capacity building, or even a diagnostic tool, GoShare has that catalogue available to you, and what you can do is you can actually push out that information to the patient so that they can engage with it in their own time, and the system feeds back to you when the patient has read that article, undertaken that assessment, or alternatively watched that self-management, utilize the self-management resources that are available there. So you receive that feedback that that they've actually gone through those resources, and that's a useful prompt. So when the patient comes back in, when you next engage with them, either face-to-face or virtually, you can check in with them to say, radio, what did you think about that piece of literature I sent you on how to best self-manage diabetes? What did you think about the opportunity for us to develop a 6-day action plan? Would that help you? Would you not? So again, not only is it a useful educational tool, but it also helps inform those decisions in terms of how you collaborate with the patient to work towards optimal health outcomes. So the link's there, feel free to do that. And that's arguably available to those tier 2 type patients. But I've also found, and Paresh in implementing it in his new practice has found, it's also useful at that bottom tier, so the population management approach at that baseline. Because often we assume that people need to understand conditions, clinical conditions, but it's not timely and relevant. They don't need to know until they need to know. So drip feeding them the information is quite useful, and that system enables that. But this complex care management is obviously at those tier 1, tier 2. So it's a very smaller segment of your population. So those people who need complex care management or case management, it's usually nurse driven. It's about delivering that targeted, coordinated and continuous care. It looks to address chronic conditions, and also it's built into the psychosocial factors, and it picks up on patient needs like homelessness, substance abuse, and so forth. So the challenging patient I talked about earlier, so those highly complex, challenging patients for whatever reason. So there we need, as I mentioned, comprehensive care, continuity of care and coordinated care. And those patients will need a higher level of support to do that. So this is required by 10% of the Australian population. So once you've developed your patient registered, you might want to benchmark, well, actually, how many patients have we got stratified in that tier 1 compared to the Australian average, which is 10%. And you may find that actually your patient profile is a lot more complex than other general practices. So for example, Angelene, New South Wales GP that has adopted the person-centred medical home model, when he undertook this, he determined that he's got very much more like 30% of his tier 1 patients are tier 1 patients within his practice. And that's because of the quality of care he provides. He's actually attracted those patients to his practice, because they know they're going to get that comprehensive, continuous care and a better patient experience, or what they perceive to be a better patient experience from him. So those patients, as I mentioned, need more frequent active support. As I said earlier, typically provided by a nurse who'd be classed as the care manager for a patient. But on the back of that, it needs a team-based approach. So we're talking here about those patients who need shared care plans. So that team-based approach will not only involve your general practice team, not only involve community-based allied health, but it will also include specialist care and specialist allied health within the hospital and healthcare system as well. So it's thinking through how do we actually coordinate and integrated services? How do we facilitate the coordination and the integration of those services to better meet patient needs? And if we extend that healthcare neighbourhood concept and thinking through the sort of map of service providers required for complex patients, it also extends into my aged care, NDIS and so forth. But it's all focused on patient needs. It's all focused on that shared care plan and the goals of care. And My Health Record is a tool that we need to utilise to ensure that all of the different players within that healthcare delivery system actually have information to hand when they need it. So communication is critical. The care planning is critical. Shared care planning is a useful mechanism to ensure everyone's on the right page, everyone's working towards the same goals of care, all determined by patient needs. And the tools we've got to help create that shared care plan, My Health Record, CDMNet, and the linked electronic healthcare record and secure messaging. Now, care within the healthcare system and the patient journey is complex. If you're a patient with very high complex needs, where do you start? You don't know which door to turn to. You don't know whether or not you're going to come across roadblocks when you get in there. And if you were to map that healthcare neighbourhood, so the map of care for a highly complex patient, it would give you an illustration of how complex that web of care is for them. And if you think about the fact that these are patients who've got high chronic care needs, but also potential psychosocial needs, it can be really challenging for that individual patient who may well have a very low level of health literacy and self-activation. The system can be very confusing. We see people drop out of the system. We see people get lost in the system. We see the gaps in care. And that's what we need to address for those highly complex patients. So the care coordination model here gives us an overview of what we can actually undertake to better support those patients. And I would advocate that care coordination should sit as close to the patient as possible and therefore should sit within general practice. But the key components of care coordination obviously reflect the different agencies and services. So the community agencies, hospital and emergency departments, medical specialists and so forth. So all the key providers within that patient's map of care need to be engaged through that shared care planning process and the delivery of care. So, and what we need to do is support those patients in the system to link and leverage, get access to and utilise the services that they need to keep them well and out of hospital. So it's reliant on high quality referrals to those service providers. It's also contingent on transitions of care of the patient across that patient pathway. And those transitions of care are the points where there's high risk of misinformation or the lack of communication of patient needs, high risk of the patient getting lost within the system. And to give you an illustration of that, I'm not classing myself as a high risk patient, but that interface, for example, between public and private care, I've experienced getting lost to the system because one hand hasn't communicated to the other hand. I don't know where I'm meant to be, and I get lost in the system of care, so forth. So, but the other key components are around the fact that actually we need to build in the connectivity, and we can utilise that by using the digital health tools. We can utilise that by actually having relationships with the key service providers that support our patients and address their needs. And we need to have those relationships both at a personal level, but also as a system level. And the way we do that as a system level is by looking to establish agreements. So thinking through the tools we've got that have agreements inherent within them is things like health pathways. So it's agreement between the PHN and general practice primary healthcare community in terms of what is the relevant health pathway with those specialist and hospital-based services within our region, and how we're going to collaborate and work together. So thinking that through. But then also what we need to think through is, well, actually, how do we build in the accountability? How do we scrutinise? How do we assess and determine whether or not the patients with highly complex needs get the services that they're needing? How do we actually measure and monitor where the care gaps are? And then what do we do about it? So what do we do as the care coordinator or case manager to pick up on those care gaps and then re-engage the patient back with that broader healthcare system or back with our general practice? And to do that, we have to build in some patient support, some patient feedback loops. So we're checking in with the patient, how they're going, have they accessed the service? What did the specialist say last week when you went to see them? Did you actually go to the appointment? Did you not? Has your aged care service provider turned up? Did they not? And so forth. So we can actually enable and support the patient receive optimal care. So I'm mindful of the fact I'm running through this very quickly, so my apologies. So care coordination can be undertaken sequentially. So if you think about that transition between a doctor going on leave and they hand over to a new doctor, so the importance of that warm transfer, the warm handover of information and a discussion about patient needs. So similarly, specialist discharges and communication back to general practice. So communication is critical for that continuous care. So parallel activities in relation to coordination, care coordination rather, is thinking through, well, actually, how do we share responsibilities to better address the patient needs? And the practice nurse might be the agent that actually ties those parallel activities together, so that there's a centralised understanding of how all of the patient needs are being addressed within that broader healthcare system. But then there's also this ability to influence those provider relationships and utilising the tools, the incentives, the educations that I've talked about. So health pathways, my health record, and so forth. How do we link and leverage them to better communicate and address patient needs? Shared care planning tools, shared risk assessment tools, and so forth would be built in that. So care coordination activities, pick up on medication management, medication adherence that we mentioned before, that's self-care support, and health education, health coaching. Advocacy and negotiation is a critical component of care coordination. So if your practice nurse takes on the care manager responsibilities, then they are acting as an advocate on behalf of the patient. So if there's identified care gaps, the practice nurse needs to be empowered to act with and on behalf of the patient, to reach out to the other service providers, to find out what the current situation is, and then facilitate that access to services or that re-engagement of services or access to equipment or access to funding, thinking about my aged care and so forth, NDIS. So advocacy and negotiation is a critical component, and you need your nominated care manager to be authorised to do that. So think through the application of standing orders so that you equip and empower those individuals to just get on and be proactive. The psychosocial support is a key element that's built in there as well, but actually the monitoring and review is fundamental. So if you think about how complex the system is for a complex patient with high chronic disease burden, high complex needs, what we need to ensure is that the feedback loops are inherent within the system, so the care manager knows when to address an unmet need, or alternatively, when there's a need to review the care plan and review what services and supports are required for the individual. So care coordination is critical to addressing the needs of those high complex patients to make sure they don't get lost in the system, they don't fall away, and actually we work towards an optimal experience of care for the individual and better health outcomes. So this is an activity that's in your workbook, and it's thinking through the patient journey and thinking through, well, actually in the patient journey, there's a number of transition points. So this illustration here is about discharge from hospital. So that scenario then begs the question, well, actually, once this patient gets home, once they're discharged from hospital, how are they actually going to re-engage with the general practice once they've been discharged? Do we know if they are actually going to re-engage with the practice? Or are they actually sitting at home in splendid isolation, assuming someone's going to reach out to them? So how do we manage that transition process? How do we actually manage that re-engagement with the patient? How do we actually know the patient's actually being discharged at all? What are the feedback loops and mechanisms we need to do that? So similarly with an ED department presentation, how do we know which of our registered patients have actually been to ED, which of them, what the outcome of that was, and whether or not they've been admitted or discharged? How do we do, what are the feedback mechanisms? Because ideally, the sooner we engage with a patient who's been through ED and admitted, as soon as we know that, then ideally, the sooner we can engage with discharge planning, the review of a patient's care plan, and identifying what their needs are once they're discharged from home. Counter to that is also those ED patients who've been to ED, been discharged from ED back to home. Do we know they've been to ED? Do we know what their care needs are? So what are the feedback mechanisms within that transitions of care that we should ideally develop so we can better address and be proactive, provide proactive care for our patients? So how's that information relayed from the hospital to your practice? Is it relayed? Does it need to be relayed? If it does need to be relayed to help us deliver proactive care, how can we, as a practice, influence that? As a region of primary healthcare service providers, influence that in building the mechanisms and the systems to do that. So interventions we've got available to us when it comes to care coordination and better addressing the needs of patients. And I'm mindful of time. I suspect I only need another 10 minutes. Is everyone okay to hang on for 10 minutes? Yeah. I'll just keep going. I know a number of you have to drop off. That's fine. So the interventions we've got the home visits, we've got a follow-up telephone call. So if we know someone's been discharged from ED, we can actually reach out to them as soon as we know, just to check in that everything's okay. So that's the timely follow-up. We've got that transition coach, so someone who facilitates the transition from the hospital or the specialist setting back to the patient home and then engages the patient with general practice. A patient hotline, so making those available, instigating medicines, reconciliation, utilising things like a discharge summary utilising things like My Health Record to ensure that communications are effective and timely. So some programs that pull together those interventions to try and address those transitional issues and to address care coordination. So the Bridges model looks at transitions, the transitional care models available to us, care transitions, interventions. So this is all premised on the fact that those transitions are high risk points within the patient journey. Services that have been put in place include the GRACE model, so looking at the needs of geriatric patients to undertake assessments, keep them well and out of hospital, Project RED, and then better outcomes for older adults. So we've got programs available to us that we could look to implement to better address the needs of those highly complex patients within our practice and within the broader health system. So when we look at all of those different programs, we can see that actually the high level transitions of care approach fundamentally boils down to this: the determination of whether or not there's a high risk of a failed transition. For example, if we don't transition this patient appropriately from hospital to home, from hospital to re-engagement with general practice, is there a high risk that that would fail? So if there is, let's work together to develop a transition plan. And then let's track whether or not we've actually addressed and there's been a smooth, cohesive and connected transition for the patient, and they're connected back to their general practice of care. So fundamentally, these transition care programs follow this process. Now, in this regard, I'd like to just invite Angelene to quickly talk to you about Queensland Health Viewer, because this is a tool that would benefit you because it provides access to hospital records for patients. Janine or Jane, are you?
Sorry, Angelene. Janine had to leave for another
Right.
meeting. She did pop something in the chat. Sorry
Yes.
about that.
That's okay. So can I just clarify, have you got access? Have you all got access to the viewer? Do you utilize the viewer? And if so, why and when do you utilize the viewer? No. Well, this is a really extremely useful tool that actually allows you to monitor your patients while they're in the hospital setting, the health system setting. And it also then allows you to engage with discharge planning, care planning, shared care planning, because actually you can see what the status of your patient is. You can see how things are changing with regard to your patient, and you can proactively engage with the hospital, the service provider, and participate and collaborate, because we're talking about integrated care and the need for integrated care for tier 1 and those complex type patients. So the viewer helps us do that. So feedback I've got through the chat boxes, most of the GPs in Mackay have access to the viewer. So I'm thinking it's great if you understand what the patient needs, if you know if a patient is actually in the hospital setting, and then it's a great tool to actually prompt that collaboration, shared care planning, and so forth. So you better understand what your patient needs, you can better influence the care plan that's put in place to address the patient needs once they're discharged from hospital. Let me just move that. So if you hadn't had the chance to play around with that, and you may recall that earlier, I think it was Suzanne said it would be useful to undertake a mapping exercise within our general practice using the chronic care model to determine what we currently have access to within our general practice, what people use, and then what opportunities are there to actually extend those decision support tools and information system support tools. So it would be useful to undertake that activity to see to what extent people within your general practice, your clinicians, actually use the Queensland Health Viewer. And Nicolette has kindly put a link in the chat box there for you to access additional information on that. So right, just a 5-minute recap then. So this is looking across the 3 webinars we've held, picking up on digital health literacy and population management. So there's the need here to sort our practice patients into populations. And that allows us to quickly identify those people who do access services, but also those people who don't come in and who aren't engaging with services or have gaps in care. So understand those population needs helps us customize our services to the needs of that specific patient cohort. So a cohort of low-level activation patients might need different supports than those highly activated patients' needs. So the registers help us segment our patients, and what we need is quality data to actually drive that reporting, drive the development of registers. So in adopting a population management approach, we need to think through, well, actually, what levels of care are needed by our patients, informed by where our patients sit within that population pyramid. So the stratification of patients based on their complexities and their needs. So how do we segment our patients and deliver services at that panel management, so the lower level of need patients? How do we develop models of care services that address rising risk type patients, and we build in those health coaching elements to look to enable and equip them with the self-management skills they need, information they need to actually stop that decline in the health condition and avoid them ending up in that complex care management domain. So thinking about the complex care needs of patients, how do we design our services and our system of care to address the needs of those complex tier 1 type patients? So key components that help us adopt that population management approach include patient registration and enrolment. So if you know what patients you're responsible for, you're then able to collect better quality data, I would suggest. You're then more able to adopt that proactive approach to care. If you're then able, depending on the size of your practice, to enroll or empanel those patients with a general practitioner or a team within your general practice, then again, you're moving down a level. So that there's aligning the responsibility for that proactive care within the care, a designated care delivery team. And that care delivery team, including the GP, being then responsible, obviously, for delivering proactive care, continuous and comprehensive care. So what we need to do that is a panel management approach where we've got the ability to actually scrub the data, determine which patients sit with each care team or which patients are empaneled with which GP. So how do we use the data to then determine what the patient needs are and the gaps in care are? And then we need to take that information, that knowledge, and then translate it into preventive, proactive care. So we talked about enrolment. So just to recap, this is about the identification of a patient population, so your patient population. It's about the ability to risk stratify that registered patient population or that panel of patients if they've been enrolled to a GP-led care team within your practice. So stratifying your patients to determine their level of need. Then we need to sort them into panels. So using registers to sort those populations, subpopulations into panels, and then using registers to address their need. It could be then quite useful to manage supply and demand, because if you determine, well, actually we've got very highly complex patients, but we haven't got the supply to address their needs, how do we address that? So it allows you to ask some really meaningful questions. How do we address that? Do we address it through increasing the supply? Do we address that increased demand by building out capacity within general practice? And what mechanisms do we have to increase capacity within general practice? So that's thinking through, well, actually, does the GP need to do everything? Or can we think about how we optimize and ensure people are working at their full scope of license? And what can be done by the practice nurse or the nurse practitioner, the receptionist or the medical practice assistant, or as Paresh mentioned, the patient advocate. So how do we build that capacity? What other mechanisms do we have? So the data allows you to ask these meaningful questions. Building capacity, as I mentioned earlier, shared medical appointments. Does that allow us to see more patients and address more of that patient need, as opposed to having that linear one-on-one consultation with patients all the time? So it's about aligning services and aligning the service model to actually address those patient needs. So if you think about your service design components to do that, so we're developing the services, developing the service model based on the needs of our registered and empaneled patients. So that team-based care approach, your GP team, including the administrative staff, your nurse practitioner, your allied health, your practice nurse, your MP, and so forth, the resources you have in team and the extended team, that allows you to adopt this population management and patient-centered care approach. And the fact is, both of these are a team-based endeavour. They should not be done and can't be done in isolation by one individual. And as I mentioned, there's the different roles. So think through in your model of care, the service delivery mechanisms. How do you actually maximise the benefit of all of your team players? How do you authorise and empower them to work at their full scope of licence? Standing orders are really helpful in doing that. Because even though, for example, I may have a practice nurse who is trained and under her, on the basis of her accreditation and training, she's capable of undertaking, or he's capable of undertaking those assessments and so forth. They may not feel empowered or confident within the general practice setting to do that. So, but standing orders allows you to adopt a standardized approach. This is what we do. This is how we do it. This is who's authorized to do it. So this gives you an idea of those different tools you can actually use for that. And when we talked about top bar, we talked about identifying the care gaps within patients. Now I'm going to leave you here with a challenge. I'm 20 minutes over. My apologies, everyone. This is a challenge. So think about diabetes care, and this is inherent within your workbook. So the lead clinical indicator there we tend to report on is HbA1c. But actually, if we're looking at a bundle of care, if we're looking about evidence-based care, there's another 2 indicators we should be monitoring for our patients. And ideally, sitting central to that, the central indicator is how many of our patients all are within the clinical range for each of these three clinical indicators. So what proportion of our patients sit here? What proportion are, in terms of cholesterol, below a score of 5? What proportion of patients sit here? But then actually, what proportion of our diabetes patients are all within the range for these three clinical indicators? And that's when we can say, well, actually, we are delivering evidence-based care. So how do we use the data? What do we record to actually determine that? So this is the population pyramid. And sitting alongside this, so this builds on that Kaiser-Permanente anti-risk stratification levels and the tiering. And this just gives you an idea in terms of the MBS items that are available to you. So using top bar, we can determine what the care gaps are. Using top bar, we can also determine what's the gap between what we actually have undertaken and are able to undertake under MBS, and what's the cost benefit of actually addressing the gaps in care we've identified. So what additional income could the practice generate? So in your workbook, you've got the knowledge capture sheet, the what, the so what, now what. So ideally, if you've got the time to go away and reflect on this webinar, my apologies for overrunning. So think through the so what. So for example, Ahmed identified earlier is going to go away and have a chat with his practice about the use of top bar. And then think through what actions. So what actions could you take or would you want to take in general practice? And that might simply be undertaking some of these activities in general practice as a starting point to determine where your practice wants to go. An activity we've left you in your workbook is to think through how will you use your clinical management system and data extraction tools to identify your top 5 chronic conditions. How do you currently identify your care gaps? And what 3 activities could you undertake to actually better address those 5 chronic conditions you've identified? And you can use the template of the chronic care model to actually engage with your practice staff, because recognizing the fact that it's a team-based approach, you need the engagement, you need the buy-in to actually ensure that your change activities are lined up for success. Another activity picks up on care coordination. So again, working with the team, identifying what processes need to change, what barriers exist, and how can you actually overcome those barriers. And then drawing back to stream 1 activity on a quality improvement approach. How are you actually going to implement the PDSA cycle? So what are your goals? What are the measures? What interventions are you going to put in place? And how will you know that they've actually been successful? So as I mentioned right at the beginning, quality improvement, data-driven improvement informs all of this. I'm going to stop here and thank everyone very much for your time. I'm happy to stay on for 5 minutes if anyone's got any questions. Again, my apologies for overrunning, but there was a lot in there. So thank you very much, everyone. And thank you, Primary Health Network, for being proactive in supporting your practices.